The topic is optimizing reproductive, maternal, newborn, and child health services in the midst of the COVID-19 pandemic, the Ghana experience. And it has been very nicely introduced by Asa. So I'm going to tell the story with enthusiasm as a former Deputy Director General and Director of Family Health of the Ghana Health Service. I'm following with keen interest, and I'm also interested in the progress of Ghana Health Service, the health in Ghana, and whatever is happening about health worldwide. So I hope we have a nice time. So in this lecture, I'm going to give a brief description of Ghana's health system, an introduction to COVID in Ghana, then the background to the development of the initial guidelines for reproductive, maternal, newborn, child, and adolescent health, some highlights of the guidelines, service guidelines, and then response and adoption to other essential health services and systems of health in Ghana. I'll give a few slides on data. We look at the lessons learned, conclusion, and what Ghana has been monitoring. And I must say that since I'm not in the Ghana Health Service, I'm depending on what they have been doing and slides shared, especially by the Deputy Director General of the Ghana Health Service, the Head of Reproductive Child Health, and other distinguished presenters who have presented several aspects of Ghana's COVID experience. So this is Ghana for you. We are located in Africa, in West Africa, and that's our flag up here. And this is the regional map of Ghana. So we have a population of about 31 million people. Our last census was last year. 16 administrative regions. The country is divided into 16 administrative regions. It used to be 10. And just in 2020, we got some divided further. So we have 16 administrative regions. Our capital city is Accra, Ghana, in the Greater Accra region. We have 261 districts. And a little about our health system is headed by the Ministry of Health, and the Ministry of Health works with agencies. We have 24 agencies, some in regulation, training, and service delivery. So Ghana Health Service happens to be the largest service delivery agency, providing services to the public and working with all the partners, also private and mission and quasi government facilities and services. Our operational levels are, we are from the national level, we have the regional level, then we have the districts, and the districts are the primary providers of health. And under the districts, we have sub-districts, and in every sub-district, we have communities. And you may have heard about the community-based health planning services, CHIPS, in Ghana. And that is the community level for our service delivery. So our service delivery is that way, and feedback goes from the top down and the bottom up. So the types of services that we have static services in the hospitals, clinics, specialized clinics, in the public and the private. And the private includes mission and other private providers, where the clients go to these clinics or places for service. Then we have outreach for places that are far to reach, and there are regular visits to these places to provide services. Then we have community-based services, where we have home visits. CHIPS is Ghana's primary healthcare way of trying to attain the universal health coverage as well. So that is home community-based services. There are also other innovations like telemedicine and some mobile services provided. So now into COVID. WHO declared the novel coronavirus SARS-CoV-2 outbreak as a public health emergency of international concern on January 31st, 2020. And Ghana was also keenly looking at what would happen in the world. Then the pandemic was subsequently cleared on March 11th, 2020. The first cases of COVID-19 in Ghana were reported just the next day after the declaration. So Ghana was working hard and had things in place to catch the cases. And just a day after, we got our first cases from the airport, the Reproductive International Airport. Followed up and found out that we had those cases. And we had one official in the initial cases who unfortunately had passed, but had some meeting with a lot of people. Some people in the health sector were part of it, so they all became contacts. So I'll talk about that later. That's a very personal story, but has led to success. Fortunately, the person quarantined and succeeded without being affected as a contact. So on March 16th, all schools were closed. A ban on all social gatherings was put in place. Starting on March 22nd, all air, land, and sea borders were closed. Then beginning on March 27th, 2020, there was a 3-week partial lockdown imposed in parts of Greater Accra, where the Quansah International Airport is, and where the initial cases and spread started. Then the next biggest region is Ashanti region, where Kumasi, the next biggest city. So we had partial lockdown in these regions. And the government had objectives outlined for the response to limit the effects of the pandemic on socioeconomic activities by limiting and stopping importation of cases, detecting and containing cases, caring for the sick, and the social and economic responses to protect the most vulnerable, improving domestic capacity, and deepening self-reliance. So, as I told you, one of our officials, she was actually the acting director of the Family Health Division at that time. She was one of the first contacts, and she had to be quarantined. So she was at home. So I picked this from the internet just to give some humor or some fun to whatever was happening. That she was, and I spoke to her. I spoke to her personally, and even also at that time, and even also during as I prepared for this lecture. And she told me in her own words that she decided that she would not be overwhelmed, she would not be anxious, but she would use the quarantine time profitably so that things could happen nicely afterwards. So here the cat says, I'm not angry, I'm quarantined. So she was not angry, and she was quarantined, and then she stayed calm. Then she contacted her team members at the Family Health Division who are providing essential services for reproductive, maternal, newborn, and child to come up to think about how we would tailor our services to address any concerns about the pandemic. So here we have people with question marks. So as she was home on quarantine, all the staff were also working. The managers and the headquarters, the regions were all thinking of how we would continue these essential services. So fortunately, she became a quarantine survivor, and the success story is what we are going to share. So as we all anticipated challenges to service delivery during epidemics, and some of these challenges are a possible reduction in antenatal, postnatal, child welfare, leading to reduced coverage of essential interventions, reduction in skilled delivery, and putting women and newborns at risk when the baby is coming, whether there's COVID or no COVID, the mother has to be attended to. And we thought that there would be delayed care seeking for illnesses in general, and there would be increased illness and death, especially for these vulnerable groups and for the rest of the population. Then there will be also reduced reproductive health services like family planning and adolescent health and development services. As they were pondering over all of this, they remembered the other experiences of the other countries like Liberia. In Liberia in 2014 during Ebola, pregnant women were abandoned and gave birth anywhere, including outside in the open, due to lack of defined guidelines at the start of the outbreak. The lack of infection prevention and control materials and fear of conducting invasive procedures such as deliveries made healthcare providers abandon pregnant women. In Sierra Leone, there was over 25% reduction in institutional deliveries during and after Ebola. So all these were concerns. And for Ghana, there were anecdotal evidence of reduction in attendance at child welfare clinics for the fear of COVID-19. So the quarantine time was over. By the time it was over, they had put together guidelines and together with the regions and others, refined these guidelines very promptly, so that by April 2020, we had the guidelines ready to be disseminated. So there was a need for a coordinated action to maintain this essential health service delivery, particularly for reproductive, maternal, newborn, and child and adolescent health. So that is the rationale for bringing those guidelines together. The objectives of the guidelines were to recommend how the health system could be reorganized to maintain access to safe, essential quality health services for women and children. The aims were to limit direct morbidity and mortality from COVID-19 and also avoid increase in indirect mortality, for example, maternal and newborn mortalities due to lack of other routine essential services. So this is what the cover of the document looks like. I had to make it a bit light because it wasn't showing properly in the slide. It's a bit darker here, right? So in this document, which came out in April, the major areas were service delivery approaches, home visits, promoting social distancing at clinics, special considerations for lockdown, for the regions and districts under lockdown, and for the regions and districts not under lockdown, different things were happening and had to be covered. Then infection prevention and control during service delivery, information and communication, very important, and other enabling arrangements. Those were the major areas in these guidelines. So under service delivery approaches, the highlights are that all routine services will continue with recommended modifications, and mass vaccination campaigns were temporarily suspended due to increased risk of community circulation and would be re-evaluated at regular intervals. So daily provision of services for antenatal, postnatal immunizations, all the services were recommended at all facilities to reduce crowding, so that every day there will be services, so that there's not a specific day that people will be coming. And then there would also be ease of social distancing. So when the services are every day, they will just come in numbers that can be managed. And then daily child welfare clinics were encouraged. They discouraged the one day in specific days for certain services. So under home visits, they were to be limited to at-risk clients, only mothers, like mothers with preterm babies, malnourished children, and pregnant women with complications, anyone needing special care. That was home visits were going to be limited to them. And then health workers conducting home visits were to wear appropriate PPEs, face masks and gloves, and carry sanitizers at all times for use, and also ensure hand washing. Then, in promoting social distancing at the clinics, we were to reorganize clinics to allow for social distancing too. And there was arrangement for open air seating, operating 2 or more clinics concurrently, so that we have smaller numbers, and providing focused antenatal care when the person is seen by one particular the pregnant woman is seen by one particular service provider, one-stop shop, and then operate appointment system with date and time for people where possible. So for the regions under lockdown, there were special considerations that the services should be mainly delivered at the static points of the health facilities. And then routine community outreaches were only to be conducted to hard to reach areas because they were under lockdown. So a lot of community work also had to cease. Now, for regions and districts that were not under lockdown, service delivery continued at the static points following the guidelines, and also in the communities following all the guidelines provided. And then they considered increasing community-based approaches, including community outreach to women, children, and newborns. So with infection prevention and control during service delivery, the disinfection of all surfaces and equipment in the clinics, during and after the clinics, mandatory triaging for all clients and providers using Ghana Health Service approved checklist before admission to the waiting area, referring when needed. Temperatures were checked and people were actually screened. And all service providers were in the appropriate PPEs. Minimum was face mask that had to be replaced daily and more often if necessary. We were to provide hand washing and sanitizing for all the clients and service providers, and all clients and providers were to wash their hands and the hands of children before being admitted to the waiting area. And they established effective patient flow, and those were done in a very innovative way on the ground. So with information and communication, it was very important to provide clients and the general public information on the current arrangements for access to routine services, contact numbers of providers for relevant services and when they had to reach them, danger signs for pregnant women and newborns using a combined maternal and child health record book, prevention of novel coronavirus infection, including social distancing, and then respiratory hygiene and recognition of signs of infection and actions to take, and also about stigmatization, the need to desist from stigmatization. So we're always repeating messages several times a day during clinic sessions. The enabling arrangements were that facilities were to adopt strategies for attending to the needs of clients who were quarantined or in isolation. The agreed strategies should be clearly communicated to all staff of the facilities. And the leadership were to consider redistributing and reassigning and task sharing to ensure continuous service delivery. Adopting strategies to maintain availability of the essential medicines, vaccines, and supplies. That was also a very interesting area. Very well done. The use of case definitions, and when the people, anyone who fell into those case definitions were properly taken care of, including vaccine, preventable diseases. They were all continued. Then there were service providers were to call the emergency number if they experienced any of the symptoms of fever, difficulty in breathing, or general body weakness. So with all these, they were also virtually, they were disseminated virtually, and the ball kept rolling down until it got to everywhere that it had to get to. And so there's some achievements were seen. For most of the indicators, the decline in coverage was seen from the period of the lockdown that occurred in the first 3 weeks in April 2020. The greatest reduction in utilization of services was seen during the first reported cases during the lockdown period from March to April 2020. Then the early response and interventions put in place led to recovery of most coverages of the most of the key service indicators, so that at the end of the year 2020, with the exception of the total outpatient department attendance and admissions, most of the other indicators had recovered from the decline. So this is what the epidemic map I took from another presentation showing things that were happening, the cases, the contacts, the major things that were happening during that time. When we got the index case, the closing of the schools, where we were asked to use the nose masks, an executive instrument was signed, it was compulsory. That's the partial lockdown here. We also had voters registration around that time, and people were very upset about it, but we were able to manage it properly as a country, with the president and everyone making appeals to people to follow what was happening properly, follow the guidelines. So these are the things that are happened. We had elections, and then we got the second wave here with the vaccinations coming in, and then the Delta variant was also came in, and then got another wave, and we are now with Omicron. So Ghana has all this data. Well, to show where the declines of the trends were, we are giving you a few examples. And this is when the lockdown started. The first case came, and this is the period up to the end of the lockdown. So between March and the end of April, we are seeing and comparing with 2018, 2019, and 2020, what was happening. So we can see for outpatient department attendance in the health facilities, we can see 2018 and 2019 very close together. You can see the obvious drop for 2020 in that period, and now trying to pick up. This is just up to June. Then for patients admissions, we can see similar trends with a drop in patient admissions during the early times of the COVID. Then we looked at malaria cases. Suspected malaria cases also showed a decline in 2020. Then there were increases in malaria deaths that period and thereafter, and the beginning of the COVID and the lockdown area. So this will also follow. We'll get the rest of the data later. This just to show the immediate achievements. Antenatal care. Here again, we have 2018 and 2019. And then you can see 2020 started very well and then came down because of all the issues. Down, and then started rising again to good levels. Now, there was also a slight decline in the trends of antenatal care registrars at the health facilities in Ghana. It was only slight, so it means that the services were going on. Now, the anecdotal reasons for disruption was fear by the health care workers, so they would not be available services, so they would be reluctant. Fear of the caregivers and the patients, so they would not patronize the service. Realignment of staff, the EPI, routine surveillance, etc., would be compromised. Then the lockdown and movement restrictions would have a lot of activities postponed. And the routine data review would show a decline in key performance indicators. So these were the anecdotal reasons for the cited for the disruption. So soon after, we had some rapid assessments from malaria in the Ghana Health Service, and it was an integrated assessment under the malaria control program and the Ghana Health Service leadership. So they looked at all the important things that they wanted to find out. And here we can see the reasons for disruption stated here. The highest was the decline in care seeking, which is about 80%. Inadequate PPEs, 75%. Fear of health workers, 70%. And coming down to rescheduling of clients for social distancing, difficult in assessing clients, cancellation of elective care. And that was you find that a lot in the surgical department. Things that were elective were mostly cancelled. shutdown of units to be used as isolation center. Stock out of commodities was 40%, and then some services not being provided due to shutdown, and then exposure of some health workers. So these are the major ones that came out with the assessment. Also, there was for the MCH, FP, RH, HIV, and malaria service disruption. The assessment looked at severe disruptions and some disruptions against the common things that were services that were being provided. So we can see here that surgical services stick out because they had the biggest disruption, severe disruption 36%, and some disruption 52%. So when you put that together, it's over 80% for surgical services. The rest are hovering here, and you can see that about 13% severe disruptions for antenatal, maternity, child illness, LLI, and long-lasting insecticide-treated nets, malaria case management, 13% severe, and then some disruption. So these are what we are seeing here. HIV testing had the lowest disruption recorded here, whether severe or some. Family planning also had some disruption. So we are looking at the demand for services. What was happening in the demand for services? Severe disruptions in demand and some disruptions. Again, you can see from the major services, surgical sticks out, and it follows a similar pattern to the previous one. And then when we have PPE, challenges with PPEs, face masks, the least affected was soap and water. That was almost everywhere with not much issues. The face shield was a major, and the N95 respirators were also very severely needed. So there were problems in assessing those. The rest we can see here, gloves, gowns, and hand sanitizer also was quite available. So, and these are the disruptions. So there is a kind of framework or conceptual framework on all what is happening with COVID. So we have the health shock, COVID, and that we have supply side issues like change in service availability, change in service readiness. And then the demand side is change in health seeking behavior and change in ability to access help. So these are very important things. We've spoken about some of them in the previous slide. And this would lead to lower quantity of essential services and also lower quality of essential services. And all of this put in context. And the context are the structure of the health system, economic resources, fragility, conflict, and the vulnerable populations, the population's trust in the health system, and the epidemiological context and biological vulnerability of the pandemic that we are facing, all have an impact on this supply, demand, and quantity, quality. And the end result here will be increased population, morbidity, and mortality. So this is a conceptual framework through which a lot of analysis has been done. So now we have the guidelines for maternal, reproductive, and child health. And the health sector itself was now increasingly moving into getting guidelines for everybody. So the malaria, HIV, and TB group also had a similar response. That's what we've seen the assessment. So they all also work together to come and together for us to extend the guidelines to cover everybody and every service, all the essential services and the health system in general. So we have an example of leadership and governance here. The Deputy Director General was assigned the task of overseeing the continuity of essential health services by the Director General. So the Deputy Director General is very well equipped with the data and things and the technical know-how to take care of the technical issues that was given to him to do. Then with governance, we had already had an initial guidance document ensuring continuity of essential health service by the Family Health Division of the Ghana Health Service. So these two leadership and governance issues led to a big health sector response to cover all essential services in the health system and the partners. So there was demonstration of improved coordination and integration, translation of national health policies into action at all levels. And then there was improvement in accountability mechanisms. And for the first, the ones done by the Family Health Division, UNICEF and JPIGO helped them with support to get it together, and then also with the printing of the first few after the virtual disseminations, including WHO also helped with the EPI and the other others to get the initial guidance. So with community participation and partnerships, the leadership, again, the Ministry of Health issued a call to action to ensure essential health service continuity. And this was shared with all stakeholders in the health sector, including civil society organizations and the health development partners. So in Ghana, we don't call them donors, they are health development partners. So the Ministry of Health shared this call to action, and then the call to action defined what was needed to be done and what showing all the things that we had to do so that things do not fall through the cracks of the midst of tackling COVID-19. So in response, the health development partners' response to this call to action, they pledged their support to ensuring continuity of essential health service and the help to the health sector and also eventually to the economy. So some of the recommendations made to government were that we should prepare a comprehensive guide on service continuity in general, as well as program-specific continuity guides, which highlight how routine services should be delivered, to integrate existing activities being carried out to ensure efficiency, and also to use the systems available for intensive COVID-19 response. Prepare a guide for re-initiation of community-based outreach services, which was suffering in the early part of the pandemic, or some had to be suspended, and adapt service delivery models to reduce the number of health facility visits so that those who take a lot of medications can have multi-month, that's an example, dispensing, so that they don't have to be coming all the time. And then also to look at how we could use digital and technology and other innovations to weather the storm we're in. More recommendations to devise fast-track services for clients with comorbidities to reduce their risk of infection, like hypertension and diabetes, the comorbidities. Provide necessary inputs to intensify adherence to the IPs at all levels, in infection prevention and control at all levels, and intensify social and behavior change communication so that we sustain public trust in the health services, and also explore options for harnessing the capacity of private providers to provide essential services. So with all this done, the guidance documents for essential services during disease outbreaks, this is what the cover looks like, now came out and has been used since then. And with that, also the Global Financing Facility conducted a virtual training to help selected staff from the Ministry of Health agencies to be able to track, to be able to look at the data and actually analyze, track, and have very good and timely response. And we'll see some of those things, results at the end of the presentation. There was also technical assistance of expert public health physicians provided for each of the 16 regions with support from Global Affairs Canada. WHO supported the development of these guidelines, and the guidelines were disseminated electronically to the regions. Hard copies were printed later and are available. So you can see how all partners came together to assist and to assist what the country was also doing under the Ministry of Health. So the general guidance that documents captured what facility managers should do, tasked to ensure effective patient flow in each facility with mandatory screening, triaging, and targeted referral, case definition, and doing what was appropriate for the cases, managing and referring, and complying with established guidelines for the positive COVID-19 positive people who are in quarantine and who had been in contact with positive cases to reduce the spread, and then allowing patients, especially those with non-communicable diseases, to book for appointment to reduce overcrowding at the OPD. So there was a lot of innovation going on in the guidance and on the ground. People also adopted it to do what would work best in their areas of work. Use of technology, telemedicine, to reduce service provider contact with clients, where some of them didn't want to actually come to the facilities. And then meetings, the major meetings were also continued. Virtual management meetings to track service performance and needed changes were made. So they didn't have to all travel back and forth. The meetings that had to be done, the decisions were taken virtually. And then there was sharing of information with public announcements, handbills, social media, etc., so that to promote continuous utilization of the health services and provision of psychosocial support for staff, patients, and relatives requiring such services. So more of the response of the health sector, there was a feedback response, and the feedback on faltering service coverage were sent to the regions. They were being analyzed. So anywhere there was any faltering, they would get feedback rapidly from the team led by the Deputy Director General and others who were actually looking at the data and analyzing it in a very elaborate way and providing feedback. Senior managers' meetings were virtually held with all the regional teams to ensure that essential services were ongoing. Regional directors also held virtual meetings with their district management teams. And then there was a virtual half-year performance review held by the Ghana Health Service in July 2021. So all the meetings that had to be done and all the decisions that would have been taken still went on virtually. So they came up with plans to ensure that their targets would be achieved. So the key activities undertaken to address demand challenges include behavior change communication that was launched with multiple channels to encourage public to use the facilities. We provided avenue for patients with non-communicable diseases to book appointments and then using technology. So these were addressing the demand side. The supply side also, key activities were that there were adequate PPEs provided. Ghana has a logistics management information system that tracks every item, and the PPEs fell right into it. And we showed and demonstrated how effective that system was to provide visibility to PPEs and ensure that shortages were promptly addressed. The government also supported local industries to manufacture face masks and overalls, face shields, alcohol hand gloves, etc. And even the local dressmakers and everybody, dressmakers, for example, learned how to sew masks and were sewing it. Now, if you sew a dress, they even sew a mask in addition with the rest of your cloth for you. So there's a lot of local industries going on. We have major ones doing. The health workers underwent training on COVID-19 and infection prevention through this is the supply side. So more of the achievements. We are now looking up to December 2020. What was happening and comparing it to 2018 and 2019. And this is Penta-3 coverage for immunization, pentavalent 3. And here again, we can see that in 2020, the penta dropped, but it caught up. So here we are. Then the monthly trend of coverage for antenatal care registrants. This is fuller than the one I showed you, the initial one I showed you before. Then we look at deliveries. Also, you see, they are also following the trends that were happening in those previous years. And so you can see that there is some catch-up. Now with the OPD, outpatient attendance, that is where we also had a lot of issues, but now you can see that for 2020, it really came down and it's also struggling to catch up. Now it's almost at where it was before. Then we have we are looking at the NCDs, monthly trend of total new hypertension cases seen at the outpatient department. Again, we see the 2018 and the 2019, and then 2020 was coming lagging behind, but now catching up. For diabetes,
Gloria, I think you muted yourself. Or it's the power connect or the internet connection, because I can't hear you.
Can you hear me now?
Now I can hear you. Thanks.
Okay, sorry, I didn't know something had muted me. Anyway, so these are the graphs for hypertension and diabetes. Hypertension and diabetes showing the drop in 2020 and the catch-up. So we are looking at the trend of institutional maternal mortality. This is the annual ones from 2014 to 2021 from the Family Health Division. So we can see that maternal mortality is following the drop and going down. For 2021, it went from 106.3 in 2020 to 104.9. So we need to do more to make the drop faster, but at least there's been a drop. And then institutional neonatal mortality too is following the drop. This is historical data. So all of this has been happening, and we have been working, Ghana has been working on it. And so the drop in institutional neonatal mortality is continuing. That trend is continuing. So what are the lessons that have been learned? The health system of Ghana has shown great resilience. And in fact, it was surprising. So in the initial slides from the Deputy Director General, has surprisingly shown great resilience in handling COVID-19 and facilitating access to essential health services at the same time. We are happy that we're able to do that. That the monitoring of key performance indicators is essential in recognizing the declines in utilization early enough to make response and interventions useful. Providing health workers with clear guidance on how to safely deliver essential services based on how the disease-causing outbreak is spread is very critical. So it has promoted confidence in health workers who are providing care and reassuring the public to utilize the services being provided. More lessons. Provision of PPEs at the staff for all the staff at the service delivery points is very essential to bring services back on track. Maintaining communication between leadership and service providers is very essential. Now, building trust in population by providing information on services available in facilities and what is being done to guarantee their safety. That facilitates essential service utilization. Lockdowns, apart from its economic impact, has huge effects on utilization of essential health services. So arrangement for offering the population essential health services should always be made if there's the need to go into lockdown during a pandemic. So concluding, in one of the presentations of the Deputy Director General, where I took these slides from and we all agree with, is that the resilience of the health system is key to sustaining essential service delivery during outbreaks. Putting into place a health system resilience assessment surveillance system that will provide information on a continuous basis on the state of the health system so that an optimal performance is always assured will be of great help in facilitating access to essential health services during disease outbreaks. So these are very important conclusions for resilience and for getting a health system assessment, resilience assessment surveillance system. And from there, that surveillance system has come and is working. And so these are some of the things that have happened. This system is a very elaborate system of analysis. And it's thus from all the reporting that we have a good reporting system called the DIMS, District Health Information Management System, where we collect and collate our data from all levels. So this is coming from all the levels. And so the team has been analyzing this data and comparing it with the previous years. In comparison to 2019, and then they had 2020, and then some up to 2021. So there is a lot of surveillance going on, and they have regular meetings. So this is the latest that was done for up to September and was presented in November. I'm sure we'll have the next one soon. So it's showing us what is happening with the service volume with 100% reporting. What has happened is that they removed the outliers. It's very well adjusted. And they have also done elaborate regression analysis to come up with these data and the inferences. So we are looking here and we see that the issues in 2020 have now for outpatient consultations. Now they have built up the outpatient consultations, so they are in the positive compared to 2019. They had dropped in 2020 because of all the COVID things. And even that, we can see that there was an increase after the initial decline in March and April. The system started moving. So we have the same for antenatal care. You can see what happened there. And for 2021, antenatal care is also up in the positives. We look at a Penta 3, and we also see that it is also in the positives, though there's some decline here. I'm sure with all this feedback, wherever it is coming from, to work now. Now, antenatal care, 4th visit, see, it's moved from the antenatal care visits were not very much affected by the COVID. So you can see that they were together, the 2020 and the 2019 were together, but you can see that there's now a catch-up. They are all above the 2 years. Then we have for family planning, that is also an interesting story here. That family planning had a big dip, but because there was also a dip in 2019, we didn't see much of a difference. But now they are also recovering. It's also recovering. And again, it's dipping down. And I'm sure that the information has gone, and wherever the issues are being tackled. So this and delivery, you can see that deliveries too are up above the 2019 and the 2020 issues. And the delivery also was not too much affected because they have to come to be delivered. Though we know that there was a few hitches, but you can see that it worked very nicely in those been in the 2020, and now they are picked up above the levels. For postnatal, a similar story, and then for BCG also. So these are some of the outputs from the analysis, the assessment. This is another interesting one. They look at outpatient consultations in Ghana during September 2021. And you can see the pink is the major disruptions of more than 15%. Green is no or limited disruptions, less than 5%, and minor is 5 to 15%. So you can see that in September 2021, the Upper West region was the only region with a major disruption. And messages have been sent there, whatever is happening is being rectified. They have these maps even for the previous presentation, so this change. I'll show you another one in the next slides. So this is for Penta 3, Ashanti region. So they have to look at it. Now, this is another interesting one, showing monthly what happened in disruptions in outpatient services. So you can see that every month the data is available to show what is happening monthly, and actions are being taken, so that the maps that are mostly red in April and May, because of pink in April and May, have now turned widely green. So it means that the surveillance is working and the feedback and the actions are going. Managers are taking, and service providers are all taking this very seriously. So this is one of the slides that talks about the summary of results of past disruptions. So Ghana experienced disruptions in the pandemic. The greatest disruption occurred in May. So after March and April, the data in May showed the major disruptions in outpatient consultations, about 30% minus 30% minus, yes, about a third down. Family planning 11, antenatal visits first -4, fourth -10. So you can see that it is BCG -8, pentavalent -4. So it's showing where the disruptions were, where they had the major disruptions, mostly in outpatient consultations. But these are all things that are being used, interpreted and used for action. There is geographic variation in the disruption of outpatient consultations. So the largest were detected in Central region in April 2020, Eastern and Oti regions, and then in Upper West region in September 2020, -32%. Now, patterns of disruption have also differed between facility types and services, but the disruptions were greatest in the hospitals, in the OPDs, the outpatient departments, the hospitals, about 34%. And the disruptions were largest in outpatient consultation volume, which persisted from March through to November, ranging from -9 to 29%. Maternal reproductive services were minimally affected. So clap for the family health division and for everybody, because maternal and reproductive health services are very priority, together with malaria and all those. But you can see that the action that took place had very minimal, showed that they were minimally affected, and that is a nice story to tell, and we have to keep it up. So the lower volume of child vaccination was observed in the first months of the pandemic and during the second wave, September and October. That is also being worked on, and now you can see that Penta has improved. So all hands are on deck, all programs are working, and all are doing their best to keep us above all of this and make the services resilient. So despite the most recent COVID-19 wave that peaked in August 2021, this was in the September report, all core essential health service indicators maintain volumes expected for pre-pandemic trends, as we have seen. So this is Ghana's story, from reproductive, maternal, newborn, and child health to the broader service delivery and the whole health system. That has been Ghana's response to keep the services optimized, available, optimized. So I have major acknowledgements to make. The Deputy Director General, Dr. Anthony Adolfo, whose slides on the presentations and others I have shared. Then Dr. Kufisa is the Director, Family Health Division, where I've also got some of the information from. Dr. Isabella Sevimus, the Deputy Director, Reproductive and Child Health Department, has also given me a lot of information, her own personal experience and how they started everything for the initial guidance. It's a personal story, and it is a teamwork story, and it is a success story. Mr. Henry Sapori is also in charge of data and has helped with some of the data that's presented here beyond what the Deputy Director General showed us for the division. That's the yearly reports that I showed for maternal and neonatal mortality. Prof. Alfred Yorson is the head of Community Health Department, University of Ghana Medical School, where I also lecture, and he has also been very much with the Ghana Health Service doing all of this and making a lot of presentations on COVID. All the hardworking managers and service providers at all levels of Ghana Health Service, Ministry of Health, the development partners and implementing partners for keeping up the good work, working together, showing leadership and commitment. We say thank you to the people of Ghana for weathering this COVID-19 pandemic storm together with us and trusting in the services and having the services so that we have good outcomes. Very grateful to our president, because all the people in Ghana are called by our president fellow Ghanaians. When our president has been leading the communication on the COVID response on the national media regularly to tell us where we are, where there is lockdown, where there will be no lockdown, all the issues. There is a team that is working, and the president himself comes out with the major policy decisions, addressing all of us as fellow Ghanaians. So we thank all the fellow Ghanaians, and we thank all leadership who have helped to bring this success story. We are not saying that we don't have challenges. There are still challenges, but this is a very good demonstration of how a country has worked to get to where they are. We still need support. We still need to be vigilant, and they are still working hard to do that. Ayupo to everybody. I thank you all for the opportunity to showcase Ghana's experience. Thank you.